Thank you very much, Mr. Chairman, and thank you to the organizers, especially Professor Enzo, for inviting me here to this fantastic theater. It's a great honor to stand here and give this lecture. I've decided to keep the title of my lecture as the same as I gave in Barcelona at the EASD, and so it fits with Professor Del Prado's lecture that you just heard. So my title is My Gut Feeling About Glucagon, and for those of you who attended my Minkowski lecture at the EASD meeting in Barcelona, feel free to take a nap in the fantastic chairs, or feel free to think about some nasty questions for me, because we will have plenty of time to discuss my results. At least I will not be bored in this fantastic room. So these are my disclosures. There are no data in this presentation that actually relates to any of these companies, but I just wanted to let you know that I sometimes work as a consultant for these companies. So when you hear the word glucagon, some of you may feel bored already, and I know that in some of you it will also trigger this nerd alert. But let me just remind you a few things about glucagon. First of all, you know that glucagon is the major counter-regulatory hormone that prevents us from going into hypoglycemia. And in fact, when you treat diabetes, as many of you do, you often use glucagon in the treatment of diabetes, and glucagon can actually save the life if you induce hypoglycemia with your medicines. So glucagon is important when you treat patients with diabetes. I also want you to remind you of Roger H. Unger, one of the godfathers of the bihormonal hypothesis. He stated that without glucagon, you cannot have diabetes. So again, if you don't know glucagon, you don't know diabetes. Thirdly, I want to remind you that many of the treatments you use in your treatment of diabetes involves the modulation of glucagon. For instance, GLP-1 receptor agonists, half of their glucose-lowering action is actually related to the glucagonostatic effect of these agents. But also DPP-4 inhibitors and insulin also modulate glucagon concentrations. And in the future, I'm sure that you will also use newer agents which are directly focused on targeting the glucagon receptor. Lastly, I want to remind you that hyperglucagonemia is a core trait of type 2 diabetes, probably as important as low insulin levels. I'll come back to that. So clearly, glucagon should be on top of your mind. And to further reduce the nerd alert factor in this presentation, I can promise you that you will not see a single data point in my presentation coming from a mouse or rat. All the data that I would like to share with you today originate from human physiology studies. So let me take you back to Roger H. Unger. He, together with Orci, published the bihormonal hypothesis back in 1975. And that hypothesis states that in combination with reduced insulin secretion, increased glucagon secretion contributes to the hyperglycemic state of patients with diabetes. And here you see the typical plasma glucagon profile of patients with type 2 diabetes in the fasting state and after having ingested a 75-gram oral glucose tolerance stage. It's very well known that patients with type 2 diabetes are characterized by this hyperglucagonemic state that has been known from all the way back to the 1970s, and I've noted the legendary Reven paper from JCEM here from 1987. So we're very well known pathophysiological trait of type 2 diabetes. And we also know that this hyperglucagonemic response from studies from Robert Richard's lab, it probably contributes with about 50% to the hyperglycemic state of patients with diabetes. So again, this is a very important pathophysiological trait of type 2 diabetes. And we have even more recent evidence using glucagon receptor antagonists that significantly lowers the glycemic levels of patients with type 2 diabetes, again underlining that hypergluconemia in type 2 diabetes is an important phenomenon contributing to the hyperglycemic state of these patients. So that should be clear now. But what we don't know is the exact mechanisms underlying this hypergluconemic state. And if you want to address hypergluconemia as a treatment target, in my opinion, it is of extreme importance to know the underlying mechanisms. So traditionally, it has been speculated, and also there has been written quite a lot of papers and textbook chapters on how alpha cells are insensitive to the gluconeostatic effect of insulin and glucose, and combined with impaired insulin secretion in type 2 diabetes, these constitute the traditional explanations of diabetic hypergluconemia. But today, I would like to put a big fat question mark to these explanations and come up with some new ideas to explain why patients with diabetes, in particular patients with type 2 diabetes, are characterized by hypergluconemia. But let's take a look at these plasma glucagon profiles once again. In this presentation, I'll try to show you some data supporting the idea that the 75% elevated plasma glucagon levels in the fasted state is related to the uptake of fat in the liver, whereby steatosis could explain this fasting hypergluconemia. And also, I will look into the post-absorptive hypergluconemia, which is also characteristic of type 2 diabetes. And I'll try to show you some data that should at least convince some of you that this postprandial hypergluconemia may originate from the gut and has nothing to do with pancreatic glucagon secretion. But let's start out with taking a look on the fasting plasma glucagon concentrations. Let me take you back to 2012 when we published this study. And actually, we didn't really think about glucagon when we made this study, but nevertheless, when we saw the results, we became a little bit surprised. What you see here are 5 groups of participants, 2 groups with type 2 diabetes and 2 normal glucose-tolerant groups. In the upper panels, you see the type 2 diabetic groups, 1 being obese, 1 being lean, and in the lower panels, you see the normal glucose-tolerant groups, 1 being obese and 1 being lean. And what you can clearly see from these studies is that the hypergluconemia of these 4 groups is not really related to having type 2 diabetes, but it seems to be more related to being obese or lean. So then we thought, so the main target of glucagon is the liver. So we started look into the liver, and we got a little help from Daniel Drucker's lab because they showed that liver-specific disruption of the glucagon receptor in rodents produced alpha cell hyperplasia. So we kind of thought that perhaps there are some signals between the liver and the alpha cells that we don't know. So Mellitus, a medical student back then from my group, he did this master thesis which he published, and he speculates that glucagon resistance builds up in the liver when the liver gets filled by fat. But at that point, we didn't know the feedback mechanism. We didn't know the factors making the communication between the liver, the fatty liver and the pancreatic alpha cells. But then we recruited some patients with type 2 diabetes again and some patients without type 2 diabetes. And again, we subdivided these groups into patients having NAFLD, that means steatosis in their livers, and also in patients having no steatosis in the livers. And Anders Juncker and Nikolai Weber here, they show that elevated glucagon levels in the fasted state only occurred in the patients with steatotic livers, independently of having diabetes or not. So that means that patients with type 2 diabetes with normal fat levels in their livers, they are not hypergluconemic. Again, supporting the notion that hypergluconemia is not directly related to type 2 diabetes, but more obesity and fatty livers. And what we also saw was that was these patients at the same time were characterized by having very high fasting levels of amino acids in their livers. And in fact, they correlated quite nicely. And when we looked into the fractionated amino acids, we could see that the mostly elevated amino acids in these patients with steatotic livers were in fact characterized by being highly glucogonogenic. So that suggests that some amino acids may constitute the regulators or the mediators in this liver alpha cell axis that I will show you some data on now. Because we also got a little bit help from across the Atlantic from Mark Soloway, suggesting that amino acids may constitute an important regulator of alpha cell hyperplasia. And then we sat down together with Jens Juul Holst, Nikolaj Weber, and Jens Pedersen, and wrote up this hypothesis article for diabetes, stating that glucagon and amino acids, they work and are linked in a mutual feedback cycle between the liver and the pancreatic alpha cells. Again, we got a little help from others, because these two Cell Metab papers, they were published in the same year, and they state that glutamine may be an important regulator of glucagon secretion, and glutamine, of course, is regulated by the liver ureagenesis, decreasing glutamine levels, and on the other hand, glutamine is known to increase glucagon secretion from the pancreatic alpha cells. And in some other mouse model, they could see that some specific amino acid transporters in the alpha cells also were important for both alpha cell hyperplasia and growth and glucagon secretion. So we were beginning to become more confident that amino acid could be important for the regulation of glucagon secretion in the pancreas. And this is the idea I would like to share with you, namely the liver alpha cell axis and its role in steatosis-induced hypergluconemia. So the idea is that under normal circumstances, the concentrations of amino acids circulating is maintained because of ureagenesis in the liver. It's well known that glucagon stimulates ureagenesis, and thereby amino acids are kept at normal levels. But when the liver gets filled by fat, ureagenesis is compromised, and that reduces the turnover of glucagon levels, and thereby circulating amino acids increases, composing a signal to the pancreatic alpha cell to secrete more glucagon, and thereby sustain a new balance between circulating amino acids and circulating glucagon. So that is at least my best explanation why patients with steatotic livers, they have both hypergluconemia independently of their diabetic state or glucose tolerant state, and also at the same time have elevated levels of amino acid. But again, we need some mechanistic insights to support that idea. And Malte Suppli now, he has become a doctor and he's a PhD student in my group. He did this pancreatic claim where he recruited some obese, otherwise healthy subjects and some lean subjects. And he also did some liver biopsies in these subjects so he could verify that the obese subjects indeed had steatotic livers, whereas the lean subjects, at least the majority of them, had no fatty livers. And then he performed the pancreatic claim using somatostatin. As you can see here from the C-peptide levels, somatostatin blocked endogenous insulin secretion. And then he gave a little bit of insulin infusion just to maintain a basal insulin level throughout the experiment. And then what he did was that he gave 2 levels of glucagon infusion, a low level of glucagon during the initial part of the experiment, and then a high glucagon infusion during the subsequent part of the experiment. And then he looked into the effect of this glucagon infusion on both glucose metabolism and also amino acid metabolism. And here you see the results for the glucose metabolism. You can see that both groups increased the hepatic glucose output just as expected. And when you look at the rate of appearance of glucose in the middle, you can see that both groups react in the same way with regard to hepatic glucose production in response to the high glucagon levels. So no sign of glucagon resistance here in terms of glucose metabolism. But when he looked into amino acids, he could see that, as expected, the lean subjects, they responded with a decrease in circulating amino acid levels because of glucagon-induced increased ureagenesis and therefore an increased turnover of circulating amino acids, whereas the obese subjects, they actually responded with a paradoxical increase in circulating amino acids. And that was highly significant when he looked into the area under curves here. So that suggests that on amino acid level turnover, there seems to be a glucagon-resistant component in the steatotic livers. And in fact, he could see that the most upregulated or the highest circulating concentrations of amino acids were related to these three very glucogenic or gluconotropic amino acids as illustrated here: glutamic acid, tyrosine, and alanine. Supporting the idea, when the liver fills up with fat, it becomes glucagon resistant at the level of amino acid turnover, increasing the circulating levels of these gluconotropic amino acids, signaling to the alpha cells to secrete more glucagon. Coming back to the liver biopsies he also took from these patients. He did transcriptomics analysis on these liver biopsies, and what he could see that there was a substantial amount of genes being downregulated and also some upregulated gene, as shown from this volcano plot to your right. Interestingly, the most differentially regulated pathways were related to the metabolisms of amino acids and derivatives, whereas, for instance, pathways relating to glucose metabolisms were much less affected by the steatosis in the liver, again supporting that glucagon acts in the liver on amino acid metabolism, and that those pathways are probably very important for physiology. Looking at some specific genes related to amino acid metabolism, namely some of these amino acid transporters, he could see several of these amino acid transporters were also downregulated in the liver tissues of patients with steatosis. And here you see the 5 specific transporters, and interestingly enough, 2 of those transporters were the same that was reported in the 2 cell metab papers from Dean and Kim that I just showed you some data on previously. What he also could see was that it was not only amino acid transporters, but also important enzymes, for instance CPS1, which is a very important enzyme in the ureagenesis hepatic nitrogen pathway. So that was also downregulated, and that has also been shown in NASH models of rodents that is downregulated in response to hepatic fat content. So what we think is important here is to provide some more mechanistic data, and in order to do that, Sofie Hedersdal from my group, she used a glucagon receptor antagonist in patients with type 2 diabetes to take out the action of glucagon in the liver, and then to see what happens to the circulating amino acid levels and glucagon levels. So the idea is, of course, that when you reduce ureagenesis, you increase the amount of amino acids, signaling to the pancreatic alpha cell to secrete more glucagon. And that was exactly what Sofie Hedersdal saw. After a single dose of this glucagon receptor antagonist, I should remind you that it has a rather long half-life, she could see significantly elevated amino acid levels concurrently with significantly elevated glucagon levels, again providing a little bit more mechanistic insights to this liver alpha cell axis. When we did evaluate the fractionated amino acids, again, it was some of these very potent gluconotropic amino acids that were mostly elevated, supporting the notion that these are important for maintaining this liver alpha cell axis. So just to sum up the first half of my talk, this is just the kind of normal way of seeing type 2 diabetic pathophysiology, with some genetic disposition over here, both in terms of insulin secretion and beta cell mass, but also some genetic disposition for obesity, contributing to obesity, fatty liver, hepatic insulin resistance, and also peripheral insulin resistance, generating this combination of insulin resistance and impaired insulin secretion, resulting in diabetic hyperglycemia. But our model adds to the idea of why these patients are also characterized by fasting hypergluconemia by suggesting that by the fatty liver results in glucagon resistance, reduced ureagenesis and amino acid turnover, increased circulating amino acids, and therefore they have fasting hypergluconemia, contributing to the hyperglycemia of diabetes. So that was the fasting hypergluconemia. Let's turn to the post-absorptive hypergluconemia. And let me share some data with you supporting that some of this post-absorptive hypergluconemia originate from the gut. The idea came from this 2007 Diabetologia paper in which we investigated patients with type 2 diabetes, the dark green curve, and completely healthy subjects, the light green curves, and we exposed them to an all-glucose tolerance test and an isoglycemic IV glucose infusion. And what you see here are the glucagon results. And if you look at the patient with type 2 diabetes, you can see when they receive the glucose intravenously, they are actually able to suppress their glucagon levels in a completely normal fashion, whereas when they receive the glucose orally, they respond with this post-absorptive hypergluconemia. The healthy subjects, they are able to suppress their glucagon levels in a normal fashion, no matter how they receive the glucose, as illustrated by the area under curves here. And you can see that the group with the difference is the patient with type 2 diabetes. And that finding has been reproduced by many groups, most lately by our own group with Asger Lund and Jonathan Bakker, showing the exact same result. But also German and Italian groups have shown these findings. And of course that made us think whether some OGTT-induced factors from the gut could explain the hypergluconemia after ingesting this glucose. We got quite a lot of critique from this paper because we couldn't account for intra-islet insulin secretion, perhaps affecting glucagon secretion from the pancreatic alpha cells. So we made this study. Again, we gave oral glucose and IV glucose, but now to completely C-peptide negative patients with type 1 diabetes. And Christine Juhl-Haar, she showed the exact same thing. When patients with type 1 diabetes in this situation, when they received the glucose orally, they responded with this hypergluconemic response, whereas when they received glucose intravenously, they were able to suppress glucagon levels in the exact same fashion as healthy control subjects shown over here during both conditions. So obviously, we are working on this theory that all glucose, because it enters the GI tract, results in hypersecretion of glucagon, whereas IV glucose bypassing the gastrointestinal tract, interacting with the pancreas more directly, has a glucagon suppressive effect. But what factors could be responsible for that? We've made several studies suggesting that it's not only glucose and insulin regulating alpha cell secretion, but also GIP from enteroendocrine K cells and GLP-1 and GLP-2 from enteroendocrine L cells. So it is starting to become quite a complex machinery regulating the alpha cell secretion. But still, nevertheless, we couldn't really get away from the thought that glucagon may originate from the gastrointestinal tract itself. So now we turn to patients without a pancreas, and we got into contact with some of our surgeons doing these total pancreatectomies. And Asger Lund, now a postdoc in my group, he recruited patients without a pancreas. Most of them had their pancreatectomy done because of adenocarcinomas, but also some because of severe painful pancreatitis. So all of these patients are very lean. Not a single one of them have a BMI above 25, just so you know. In the middle, you can see the blue parts of the anatomy being removed during the operation. So what he did was that he did these experiments again with all glucose tolerance tests and isoglycemic IV glucose infusion, obtaining isoglycemia using an adjustable IV glucose infusion. And you can see that these patients clearly have secondary diabetes after their pancreas is taken out, illustrated by the very high plasma glucose levels shown here. I just wanted to show you that he were able to achieve isoglycemic during these conditions. And here you see the C-peptide results, and I just want to show you the completely flat C-peptide curve for the patients down here, illustrating that they have no remnant pancreatic tissue left. And for the healthy controls, obviously see a nice incretin effect during these conditions. And now turning to the most important results, namely the glucagon results. Here you see the healthy control subjects being able to suppress glucagon levels no matter how they receive glucose, as we have seen now several times before. But when you look at the patients, you can see that they actually respond when they receive the glucose orally with a remarkably high glucagon level. Just to remind you that when you have a patient with type 2 diabetes in hypoglycemia, that patient will respond with glucagon levels in the range of 20 to 30. So close to a very prominent response during hypoglycemia. And remember that these patients, they don't have a pancreas. And also what was interesting was that they were actually able to suppress their glucagon levels just a little bit when they received the glucose intravenously, suggesting that these patients without a pancreas, they are able to secrete glucagon, and somehow it acts by being suppressed when glucose is infused intravenously. So we also did some mass spectrometry to make sure that in fact it was glucagon and not some other pro-glucagon product. And as you can see down here, the most potent signal is from the OGTT at 30 minutes when glucagon levels peak. And you can see the only response we see is when we investigate the 29 amino acid sequence of glucagon. So we're quite confident that it is glucagon we are seeing. Interestingly, when we looked at other interendocrine hormones, for instance GIP, we didn't see any differences. But when it came to other pro-glucagon-derived interendocrine hormones, we could also see these remarkable increased responses with GLP-1 and oxyntomodulin coming from pro-glucagon. And let me just remind you about pro-glucagon. This is the precursor of glucagon. When that is processed by pro-hormone comatases in the pancreas, PC2, it is processed into glucagon, as illustrated here. When it's processed in the gut, it is processed by PC13 into GLP-1, GLP-2, and glycine, which is further processed into oxyntomodulin. So the idea is that the presence of these pro-hormone comatases is very specific. But maybe it is not as specific as we read about in the textbook. Could it be that PC13 was present in the pancreas and PC2 was present in the gut? So we've also looked into that. Another explanation could be that these pro-hormone comatases, they are not as specific as we read about in the textbooks. So we went down and took some biopsies from patients with type 2 diabetes, and we looked with a PC2 antibody, and we could actually see that quite a few of these interendocrine cells, they stained for PC2. And when we counted these cells, it was interesting to see that the patient with type 2 diabetes, they had around 50% more PC2 positive cells compared to the controls. And when we did some co-stainings, we did find, I must admit, just a few of these cells that co-stained for a pro-glucagon product, in this case GLP-1 and PC2, and that should enable this cell to produce glucagon from the precursor pro-glucagon. Mille Bækdal, she also did an enteroscopy studies in totally pancreatectomized patients, harvesting biopsies from all these 6 points here, and these are, of course, the healthy controls and the type 2s, and over here you see the pancreatectomized patients. But nevertheless, she obtained biopsies from 6 positions in the gastrointestinal tract of these patients. 8 patients in each group. And what you can see here is that the pro-glucagon expression was significantly higher in the pancreatectomized patients, but that, of course, is not evidence for glucagon secretion, because that could also increase GLP-1 expression and so on, secretion. But when she extracted the peptide, she could actually see that these patients, in these biopsies, the content of glucagon itself was much higher in the pancreatectomized patients, and also in the patient with type 2 diabetes. I am done in a few minutes. So we also use this new glucagon antibody. That's a C-terminal wrapping antibody, which is highly specific for glucagon. And I just wanted to show you this picture because I think it's so beautiful, showing that this cell is basically full of glucagon, and the structure of this cell is very characteristic for an enteroendocrine cell. So when she counted all these cells being positive for glucagon, she could see that the patients without a pancreas, they had a much higher number of antibody-positive cells. And I forgot to mention, she also gave a glucose infusion down to the gastrointestinal tract of these patients. And what you can see over here in the area under curves, that patients without a pancreas, they respond with very high glucagon concentrations, similar to what we have seen in patients with type 2 diabetes. And again, she could also, by antibody staining, see some merge staining in some cells, suggesting that these patients, they have cells producing glucagon from the gastrointestinal tract. And with that, I would like to finish my presentation and just showing that perhaps glucagon should be put on the top of this list of gastrointestinal hormones. Thank you.
Thank you for this brilliant presentation that now is open for discussion. So I can start with the first question before Marco. I can start with the first question, and congratulations for all this data that open a new perspective in the pathophysiology of type 2 diabetes mellitus. I would like to know if in other conditions like obesity, like hepatitis or some other liver dysfunction that can lead to higher concentration of amino acid, can lead to a higher secretion and expression of glucagon. So there is this sort of mechanism that you find type 2 diabetes mellitus is also reliable in other conditions to understand better this mechanism of correlation between the liver and the glucagon secretion.
So if there are other conditions characterized by the same patterns of hyperglucagonemia and high concentrations of amino acids?
Other conditions that lead to higher satosis level in the liver can have similar mechanism.
Oh yeah, I mean, we can start with the most extreme conditions. For instance, there are some glucagon receptor mutants, also human glucagon receptor mutants, and if your glucagon doesn't work, you will have lower amino acid turnover, and these patients are characterized with severely elevated amino acid levels and some swollen pancreas due to alpha cell hyperglycemia. That's an extreme condition, I know that. If you look at the liver, it's also quite well known that patients with, for instance, cirrhosis, they are also characterized by hyperglucagonemia. And I think it's important to understand that amino acids, they can be toxic. Some of their substrates, they are metabolized into, what's it called? I forgot the name. Ammonia. And probably an important function of glucagon is to increase, to help the body get rid of ammonia. So that is probably one of the most important functions of glucagon, perhaps more important than maintaining glucose concentration. So I've not, come across a condition that does kind of contradicts what I've been saying today.
Okay, thank you. Francesco, please. A little girl, please.
Okay. Yeah, Philip, it was a great talk and wonderful data. I really like the link between fatty liver, nervousness, and glucagon. But you did only in one of your summary slides, you mentioned insulin resistance. But you've seen in our data and replicated in many, many other studies that the fatty liver really is seen in the insulin-resistant subgroup of type 2 diabetes. So I would love to see in your data the clustering done, because it looks like this issue really would relate to that insulin-resistant subgroup where we see fatty liver.
Oh yeah, maybe I should have, emphasized that I'm not taking away insulin resistance from type 2 diabetes. I totally acknowledge that insulin resistance in type 2 diabetes is extremely important for for their hyperglycemic state as well. And I think the two, insulin resistance and glucagon resistance, actually go hand in hand, contributing to the hyperglycemia, perhaps in equal contributors. But insulin resistance is a strange, at least hepatic insulin resistance is a strange phenomenon actually, because these very high insulin levels that we see, we don't really have a good explanation for the mechanisms eliciting these very high insulin levels, because you can be very insulin resistant and having completely normal glucose level, but still very high circulating insulin levels. And my take on this is that perhaps circulating amino acids are also very important for the hyperinsulinemic state of obese normal glucose tolerance subjects. So perhaps you should include circulating amino acid levels in your model.
No, it's quite possible. But also, if you look into the subgroups, that in that insulin-resistant subgroup, with a high risk of fatty liver and diabetic kidney disease, they have very good glycemic control. So I totally agree with you. But I think
Thank you.
Try to do a little more
definitely.
of this subgrouping.
Professor Purello?
If we introduce insulin resistance together with hyperglycemia and fatty liver, then actually you question a little bit the old bidirectional hypothesis that insulin, it's really the low insulin that goes together with high glucagon.
Yeah, insulin levels are, should be seen in the context of insulin resistance. I think we all know that all patients with type 2 diabetes, they have relative insulin insufficiency.
Professor Purello?
It was a pleasure to listen to your talk in Barcelona. It was a pleasure again to listen to your talk here, because new idea come. I find very interesting, in particular, the data or DC2 overexpression in type 2 diabetes. And the question is there any, what is your gut feeling about what can cause this? What may cause this overexpression of PC2? Is there any sign of cell heterogeneity? So cells that can express more are different from cells that can express less? Or is a kind of metabolic or hormonal regulation on this?
That's a very good question, and I can only, tell you about the data we have from the liver biopsies, and the only differences we actually see, or the most clear differences we see, are those from the amino acid transporters and those from some of the enzymes governing ureagenesis. And we can see they are all suppressed in the fatty livers. So our idea is that when your hepatocyte is becoming full of fat, then it simply reduces its amino acids transporters and also slows down the system of ureagenesis.
I was talking about the PC2 expression.
Of the PC2?
The PC2, the protein convertase, excuse me.
Oh yeah, the PC2. That's also, we do find PC2 in the gut in some of these enteroendocrine cells, but we believe that when you take out the action of glucagon in the liver, you increase circulating levels of amino acids, and these amino acids, they affect cells that produce pro-glucagon. So they also affect the cells in the gastrointestinal tract that produce pro-glucagon. So these cells are kind of upregulated, and perhaps they are also changed in a way promoting gut-derived glucagon now that the pancreas cannot produce enough to increase ureagenesis to a normal level. So perhaps these amino acids ask the help from the gut as well.
Philip, your model you're proposing, it's relating all the feedback, amino acid, ureagenesis, and glucagon. What happened in the pancreatectomized patients?
Yeah, that's a very good question. Of course, we have also looked into amino acids in totally pancreatectomized patients, and many of us, especially also Italian researchers, El Fianini, have also done that many years ago, and it's very characteristic for totally pancreatectomized patients that they are characterized with very high circulating levels of amino acids. And when you infuse glucagon, they drop immediately. So the next thing we are going to do is to provide a glucagon pump to these patients to see if we can correct their circulating amino acid levels.
But the question is, I understand that, actually we also did that work and actually followed up, the changes in the amino acids during pancreatectomy in these patients. And you see, with the removal of the pancreas, progressive increase in the amino acids. And it's mainly gluconeogenic amino acid that goes up, which makes a lot of sense.
Yeah,
but my question, the other way around is, now you showed that in pancreatectomized patients, you have, in response to a stimulus, an increase in the glucagon concentration. What happens in the amino acid concentration during the same condition? Are they dropping?
Well, that's something we are awaiting those data. We have the total amino acids data for the OGTTs, but now we are waiting for the fractionated amino acids data. So I can't tell you. My take is that when glucagon levels go up, I kind of hope to see that the gluconotropic amino acids goes down, but I don't know yet.
And what about ureagenesis? Have you looked at these pancreatectomized patients about ureagenesis?
No.
Thank you.
Professor Bonora.
Thank you. Very nice talk. Some of the glucose-lowering effect of GLP-1 analogs was attributed to the effect of suppression of the alpha cell within the pancreas with reduction of glucagon. So I'm wondering if we can speculate that some of the effect is due to the suppression of enteroglucagon production by GLP-1.
Well, that's a very good question. We are trying to tease out how this glucagon works. So we have got our hands on the glucagon receptor antagonist from Eli Lilly, and we are actually trying to tease out, using that glucagon receptor antagonist, 2 patients without a pancreas to see if it has any biological function that glucagon. Because it can also be that glucagon coming from the gut, another place than the pancreas, may act differently on the liver compared to pancreatic glucagon. And so currently I cannot tell you if it has any biological function, but I can come back next year and tell you.